Good evening, good morning, good afternoon, wherever you are in the world. Thanks everyone for joining us for this second webinar masterclass from CRE Reduce for 2021, where we're focusing, of course, on delivery of parenteral therapies in different environments. Our focus is typically on antimicrobials, but you'll see in some of the presentations today that we are looking at other drugs as well. So it's a pleasure to have you all joining us. As you know, this is a series that runs throughout the year, of which we have 4 of these webinars, and that's just part of a greater education program run by our centre. Before we go any further, I'd just like to acknowledge the sponsors of this, our research program. Pfizer, Baxter Healthcare, CHU Nîmes, so a hospital university in Nîmes, and Gilead Health Sciences as well. So thank you very much to them. I'm going to introduce your chair for the night, which again is the brilliant Dr. James Pollard. Makes excellent presentations seem even better, and the question and answer session as engaging as can be. So it's wonderful to have James on board again. James is from Cabrini Health in Melbourne, and he's a real Australian and international leader in the area of OPAT and hospital in the home. And it's a pleasure to introduce him. James.
Thanks, Jason. That's very kind of you. And look, I'm privileged and honoured to be able to chair tonight's session with some excellent speakers lined up, and I hope everyone's really looking forward to it. So without further ado, I will introduce Mr. Matthew Rawlins. So Matt is the Antimicrobial Stewardship Pharmacist at Fiona Stanley Hospital in Western Australia. And Matt has published peer-reviewed articles and book chapters in infectious diseases and the AMS literature. He was the first author for the COPAT/HITH chapter in the most recent therapeutic guidelines antibiotic, and recipient of the SHPA Australian Clinical Pharmacy Award for 2019. Matt's going to give us a perspective all the way from the west of a model and case study of OPAT and HITH and infectious diseases ambulatory care more broadly. Thanks, Matt.
Thanks very much, James and Jason, for inviting me to talk. Sorry, my computer is a little is struggling a bit, so I'll be asking Luminita to change slides for me. If I could have the next slide, please. So back in 2014, when my institution was being commissioned, Fiona Stanley Hospital, we were all ready to set up and plan a HITH program. But when we attended the planning meetings, we discovered very quickly we weren't actually permitted to call it HITH or hospital in the home. It's because we no longer had our own nurses nor virtual bed days, and the service had been contracted to an external community nursing service called Silver Chain, which I'm sure many of you are familiar with. Could I have the next slide, please? So I'll just run you through the sort of patients and infections we see on our program before describing the model. So this is data from last year, age mean nearly 60 years, predominantly male, a small proportion of Indigenous patients. Once a patient was referred to our program, the vast majority were accepted onto the program, and those that weren't the vast majority were actually transferred to another service, or a small amount had outstanding inpatient issues. For example, still required inpatient management for infective endocarditis. And there were no patients refused for being active intravenous substance users. Next slide, please. So this is the number of patients accepted and referred. Vast majority received their antimicrobials via a PIC line, and with a small amount receiving, still having peripheral catheters, a Hickman line, or subcutaneous administration, and I'll come on to that shortly. The mean IDAC days was over 50, but that was really due to some significant outliers who were, for example, advanced lung or haematology patients who were on the program for very extended periods of time, and our median length was just under a month. In terms of adverse drug reactions reported, or adverse reactions, I should say, rather than drug reactions, there were PIC associated problems in about 20% of these, ranging from thrombosis, bloodstream infection to exit site infection. There were antibiotic-related adverse effects around just over half, infection-related problems associated with uncontrolled infection, usually, or superinfection, and unrelated or other infections, issues in another small minority. It's resulted in 39 readmissions during this time, and about half of these, or about just under 4%, were related to the reason they were on the HITH program or the IDAC program and were unplanned. Telehealth, we reserve for exclusively rural patients, so we do have telephone reviews, particularly in the COVID era, for some local patients. Next slide, thank you. So in terms of our outcomes, so cure reported in just under 20%, improved, allowing oral switch in 70%, and with a failure rate of just under, or 8.5%, and most of these were HITH-related unplanned readmissions. A few odd cases with no improvement, requiring unplanned surgery or, in fact, death. And there was a small amount that was non-accessible. So in terms of the next, the previous year, just for comparison, similar numbers and demographic, only and acceptance rate as well, and refusals for where a few patients where IVs were not deemed to be required by the infectious diseases team, again transferred to another service, and then there was actually one refusal for active substance use. Vast majority of infections, I'm sure in common with other programs, osteomyelitis, septic arthritis, so bone and joint infection at around 40%, although some diabetic foot infections are also classified as OM, obviously. We've also seen a significant number of endovascular infections, primarily infected endocarditis, some complicated skin structure infections, bacteremia and sepsis, empyema and lung abscess, and then a few intra-abdominal infection, pyelonephritis, ENT, predominantly malignant otitis externa, and resulting mastoiditis, the occasional CNS infection, and which is primarily cryptococcal disease, and also the odd eye infection. Next slide. The common pathogens, primarily methicillin susceptible Staph aureus, around a third, 12% of the Staph aureus is around 30%, and MRSA is around 12% of these. We see a bit of Pseudomonas, E. coli, coagulase negative staph infection, particularly associated with prostheses, Viridans streptococci, and Enterococcus, often in the infective endocarditis setting, Polymicrobial infections are pretty common, and we see about 3% of fungal infections, and there are a small proportion as well that are culture negative. In terms of commonly used antimicrobials, similar, I'm sure, to other programs, flucloxacillin, cefazolin, ceftriaxone, piptazo, benpen, ertapenem, mero, and vancomycin. The next sort of tier down, teicoplanin, oral rifampicin, metronidazole, cipro, and then we have the sort of the less common agents such as daptomycin in our program, and I'll mention a bit about this later, cefepime, some antifungals, cotri, gentamicin mainly for synergy, amikacin for our MAC and other mycobacterial infections, and other agents as required. We do use the odd bit of imipenem, but that has to be coordinated with multiple visits per day. So in terms of, from a drug point of view, contentious or slightly unusual practice in our program, we do use a bit of subcutaneous antimicrobial where there's difficulty in getting IV lines in. And as I'm sure some of you are aware, there's data from Europe, primarily France, I believe, where ertapenem, teicoplanin and ceftriaxone have once daily antibiotics have pretty good PK data, albeit some small case series in some instances, showing equivalence with IV administration. And basically these are given by a subcutaneous infusion into the sort of normally the abdominal region, and using the same method of administration as you would for an IV infusion. We also, in common with other programs who deal with mycobacterial infection, deal with other unusual antibiotic regimens such as high-dose cefoxitin, 12 grams a day, and other MAC and mycobacterial agents. And we also are happy to use meropenem. I know some providers will make you sign a waiver, but we've based our use on Lawrence Manning, one of our ID physicians, paper a few years back, which showed that you could use 2% infusers up to 4.8 grams. And in fact, we have used one megafuser, which our local supplier managed to get hold of, where we had a 6-gram meropenem dose, and the patient was deemed a success. Next slide, please. So our IDAC service model, infectious diseases, physicians have governance. All patients going on to IDAC have to have a primary infectious diseases consult via our electronic referral system, e-referral, as an inpatient. And then they subsequently receive an IDAC consult, again via the same mechanism, where the IDAC team, the registrar usually, along with silver chain nursing induction to accept the patient before discharge. All the nursing care is outsourced to silver chain locally in the metropolitan area, and I'll describe variances shortly. And antimicrobials are outsourced, although the cost allocation varies. And one of the deficiencies of our program is we only have a junior pharmacist on a P1 pharmacist who's principally a supply issue for the first dose of antimicrobials. Next slide, please. So in terms of this system primarily set up for the metropolitan area in our catchment, so ID governance, we have weekly clinics, as is in common with most other programs. COVID, in the era of COVID, we were conducting telephone reviews, and Silver Chain are actually also contracted to bear cost responsibility for ongoing antimicrobials. So they selected a local company called Pure IV who manufacture all our infusers and supply all parenteral antimicrobials. There has been the occasional balking at high-cost agents such as liposomal amphotericin, Ambisome, where justification was required to be provided by the hospital to the provider, which stuck in the throat of some. In terms of antimicrobials, the FSH, so our pharmacy supplies the first dose, and this is usually obtained from Baxter. So we make no infusers on site, although we have a fully functioning sterile and cytotoxic unit. Complex orals, either PBS or non-PBS, are supplied by us and costed at FSH from FSH. Pure IV have been contracted to provide the ongoing supply of infusers and injections, as I mentioned. The occasional exceptions include Ambisome, where we actually had some problems with their infusers, which didn't deliver the dose accurately or sufficiently. So we actually had to, all of that, any patient on Ambisome receives Baxter infusers. Next slide, please. If a patient is in the metropolitan area outside of our catchment, we commence the care and we offer the patient the choice to either stay with our service or to transfer care to a local, another local program. And maternity and paediatric patients usually go back to home service, and this is to their home service, i.e. the Perth Children's Hospital or King Edward. And generally, and this is more due to nursing, the silver chain nursing requirements rather than our direction. Rural patients, this is divided into whether there is an existing local HITH service. So the discharge is coordinated by the IDAC registrar and the FSH home team. There's a treatment plan from FSH. The overall governance of patients on the program itself is devolved to the local HITH program, for example, Bunbury, Albany, Geraldton. Ongoing telehealth review is provided by FSH, for example, for more complex patients such as infective endocarditis. And we normally provide the first few doses courtesy of ordering from Baxter, and then ongoing supplies taken on by the local HITH program. If there's no local HITH, then FSH, infectious diseases governance, is maintained by telehealth, and we provide the ongoing antimicrobial infusers or injections ordered from Baxter, and the patient attends a local hospital or GP surgery for administration. One thing that we're grappling with in our program at the moment is how to treat resistant gram-positive infections. Sorry, previous slide, thank you. We're all aware of the gold standard vancomycin. There's some requirements for monitoring and potential for toxicity. There's concerns over the use of ticaplanin for many severe deep-seated infections, although this fears can perhaps be allayed by using therapeutic drug monitoring and to guide dosing. Daptomycin, I'm aware of recent programs that have moved to use daptomycin for expediency and the need to, and the desire to avoid monitoring and toxicity of vancomycin. And however, there are cost implications which are becoming less marked. Then we're also starting to use in our difficult, chaotic populations, dalbavancin, which is available SAS, but there are a number of issues associated with this. We don't really know how to dose it yet, I think, particularly for infections such as infective endocarditis. Patients often don't turn up for their follow-up dose. As you know, you give a dose, an initial dose of 1 gram or 1.5 grams, and then follow it up with a second dose a week or so later. The patients frequently don't turn up for this second dose, and we really don't know, therefore, if patients are not turning up for follow-up, what the efficacy of this drug is. But it is something that we're becoming more interested in. So in conclusion, I think you can make hybrid models work. There are difficulties associated with this because, for a start, there's more moving parts, and different organisations have different guidelines, for example, about the sorts of patients that they will accept. We need a senior clinical pharmacist definitely as part of this on the ground with this program, and we have still been able to have a decent research output, even with some of these difficulties. And finally, I'd just like to acknowledge John Dyer and Paul Ingram from ID and PathWest, respectively, for their help in preparing this presentation.
Thanks, Matt. That's a fantastic overview of your service, and we've had a few questions, and we've just got a couple of minutes till we're due. So just a couple of questions about your C. difficile rate. Do you have any measure of that, and can you attribute either pre or post hospital to that?
We have had occasional cases of CDI, and that has been has required obviously treatment or modification of therapy, but it's certainly not common.
And then, thank you. And then a couple of questions about the low percentage of ATSI in your cohort. Does that represent your part of Perth, or is that a massive underrepresentation compared to population?
No, it's no. I'd be interested to know what other programs around Perth do, but it's. I'm unsure if it's our local population, but we don't actually get a great deal of at Royal Perth, for example. They get a lot of. I've worked there for many years. We get a lot of RFDS, Royal Flying Doctor transfers down there. We tend to get less of that. So this is probably more reflective of our baseline surrounding population.
All right, thank you. And there's a compliment there to you in the Q&A, just saying they were impressed with your low readmission rate. So well done.
Thank you.